So, good evening, everyone, and welcome to today's wonderful evening with Dr. Murli Bhardwaj. And in the next 190 slides, we will run through the most essential things that you need to revise. In about 3 hours, you can revise entire pharmacology. Let's see the game. Cephalosporins, one of the favorite questions. You should remember which generation is which one and what is its special purpose. First generation, cefazolin and cefalexin, which is used on the gram-positive cocaine. For surgeons, it is a favorite one. Cefazolin is used before surgery as a preoperative antibiotic to prevent the wound infections commonly caused by the Staphylococcus aureus. The second generation are cefaclor, cefoxitin, cefuroxime, and cefotitan. They're also effective on gram-positive, right? Then third generation is 3, ceftriaxone, cefotaxime, cefpodoxime, ceftazidime, and cefixime. They're all used against the serious gram-negative infections, which are resistant to the regular beta-lactams and ampicillin and penicillin and all that. Gram-negative organisms are also covered first time by the third generation, and it can cross the blood-brain barrier, right? That's another advantage, so that it can be used in meningitis. So ceftriaxone is the favorite drug for meningitis. Ceftazidime, you need to remember because it is anti-pseudomonal. It is anti-pseudomonal. Then fourth generation is the cefepime, which is active on the gram-negative, and it also has an activity on the pseudomonas and gram-positive. Now came the generation of fifth generation, ceftaroline. It is very broad gram-positive, gram-negative, unlike the first to fourth. It also covers the methicillin-resistant Staphylococcus aureus and Enterococcus faecalis. But even though it is powerful on all these, still we can't forget third and fourth because they are anti-pseudomonal, like ceftazidime. This is not anti-pseudomonal. So that is a common trap in the NEET PG. So what are the organisms not covered by the first to fourth and only covered by ceftaroline? You should remember male. MRSA, atypicals like chlamydia, mycoplasma. Mycoplasma don't have a cell wall. Chlamydia and listeria monocytogenes and enterococci. These are the ones which are not covered by first to fourth generation cephalosporins, is what we should remember. Then what are the beta-lactamase inhibitors? Remember CAS, clavulanic acid, avibactam, sulbactam, tazobactam, and often we combine them with the penicillins, like amoxicillin, clavulanate, ceftazidime, avibactam, ampicillin, sulbactam, piperacillin, tazobactam, 4.25 grams of piperacillin TID, life-saving for the patients in the intensive care unit, right? Now, doctor, this is how amoxicillin, clavulanate, this is how you have ceftazidime, avibactam, then you have ampicillin, sulbactam, piperacillin, tazobactam. That is the story. Clear? Yeah. Very easy. Pharmacology, very scoring. Now the favorite question. Which are the inhibitors of 30 years and which are the 50 years? By at 30, cell at 50. By at 80 is aminoglycoside tetracycline. Cell at 50, chloramphenicol, clindamycin, erythromycin, linezolid. These four are 50 years inhibitors. 50 years, 30 years are the two types of ribosomes. Yeah. Now, full. Then how are tetracyclines? కొంచెం ఇది ఆఫ్ చేద్దాం ఒక్క ఫ్యూ మినిట్స్ మళ్ళా ఇంటర్మీడియట్ గా Good to see 5 online classmates. Can you please punch? Is the voice loud and clear for all of you, doctor? Now, tetracyclines, what is the mechanism? They're bacteriostatic. They bind to the 30S at aminoglycoside and tetracycline. And they prevent the attachment of the amino acyl tRNA. tRNA brings the amino acid and need to drop. For that, it need to come and bind, right? So that step is prevented. They have a very limited CNS penetration, not useful for meningitis. Doxycycline is fecally eliminated. That's the reason if the patient has got renal failure, you can safely give doxycycline. Don't take the doxycycline with the milk, antacids, or iron-containing preparations. That is a very important caveat. Now to the indications of tetracycline. Borrelia burgdorferi, which lead to Lyme disease. Mycoplasma pneumoniae, rickettsia, chlamydia, and acne is caused by Propionibacterium acnes. Doxy is very much helpful. Good news to all the people who have acne. Doxycycline is also effective on the community-acquired MRSA. Such a powerful drug. And because we are rule in Delsa, if somebody has a fever, it is not resolving, try a doxy. It will resolve. Then what are the side effects of doxy? It can lead to photosensitivity, discoloration of the teeth. It is teratogenic, avoid in pregnancy. And in children, the tetracyclines, exception is doxy. Among tetracycline, doxycycline is a type. Then resistance, what is it due to? Because the decreased uptake or increased efflux from the bacterial cell wall. So remember, amino acyl tRNA, which is bringing the amino acid, is being prevented from giving its amino acid because of the tetracycline. Then comes antifungals. Amphotericin B, it binds with ergosterol, which is very unique to the fungi. It forms pores inside the membrane. It causes the leakage of the electrolytes from the fungus. So it creates tearing holes in the fungal membrane. That is the mechanism. So what are the side effects, doctor? Cryptococcus. It is active against the Cryptococcus. Where whenever there is any cryptococcal meningitis, especially in the HIV patients, we give amphotericin plus flucytosine. Blastomyces, coccidioides, histoplasma, candida, mucor. Mucormycosis is very common during the COVID time. Amphotericin, amphotericin was sold in black market. Utna mucormycosis aage COVID ke time pe. And always, whenever you are giving amphotericin, supplement potassium and magnesium. What are the side effects when you give amphotericin, doctor? Fever, chills, hypotension, nephrotoxicity, arrhythmias, anemia. But most important, hypotension, nephrotoxicity, fever and chills. Just like you got a urinary tract infection or something like that, the patient will go into fever and chills in intensive care unit when you are running the amphotericin drip. And whenever amphotericin is being given, a nephrologist is called to give a consultation because amphotericin can lead to nephrotoxicity. Already if urea creatinine is high in a intensive care patient, giving amphotericin need a dose modification. That's the reason to decrease the nephrotoxicity, amphotericin is given as a liposomal amphotericin preparation. So what it is, doctor? Amphotericin liposomal preparation is what we should remember. Then flucytosine. How does it act? Flucytosine inhibits the DNA and RNA biosynthesis. Typically, flucytosine is converted into 5-fluorouracil. Uracil is one of the amino acids, one of the nucleic acids for the formation of the DNA RNA. वहां जाके ये मैं बोलता है कि मैं असल में फ्लोरोसिल हूं, वो यूरासिल हूं, वो नहीं बोलेगा. Competitive inhibition. So flucytosine become 5-fluorouracil become inhibitor of the DNA RNA biosynthesis in the fungus. So whenever cryptococcal meningitis is there, flucytosine amphotericin combination is used. But flucytosine also will go and affect the DNA in the bone marrow where the myeloid, erythroid, all these cells are proliferating. That lead to myelosuppression, right? So this is how Dr. Flucytosine tablets 500 milligrams. So flucytosine become 5-fluorouracil, which will go and inhibit the RNA and DNA. Don't forget. Then, doctor, azoles are the next group of antifungals. Clotrimazole, fluconazole, itraconazole, ketoconazole, miconazole, voriconazole. What do? They all go and inhibit the fungal sterol, ergosterol synthesis by inhibiting the cytochrome P450 that converts the lanosterol into ergosterol, which is a key component in the cell membrane of the fungus. So where do we use? In HIV, candidal infections, we use azoles. Itraconazole is used for blastomyces, coccidioides, histoplasma, sporothrix. What is sporothrix? Gardeners typically when the rose prick ఉంటుంది కదా అది గుచ్చుకుంటే ఇట్లా ఫ్లెబైటిస్ లాగా స్ప్రెడ్ అవుతుంది, థ్రాంబోఫ్లెబైటిస్ లాగా. రోజ్ ఉంటుంది కదా, రోజ్ ప్లగ్ చేసేప్పుడు అది గుచ్చుకుంది అనుకోండి, దాంట్లో స్పోరోథ్రిక్స్ ఇన్ఫెక్షన్స్ దే గెట్ ద థ్రాంబోఫ్లెబైటిస్. ఓకే, దట్స్ కాల్డ్ gardener's rose prick. Then clotrimazole, miconazole are used as ointment, topical fungal infection. Similarly, in immunocompromised people, aspergillus infection is very common. Oriconazole is used for aspergillus and candida. Isavuconazole is used for aspergillus and mucor. Now, what are the main side effect of azoles? Azoles can go and inhibit the testosterone production, especially ketoconazole. దాంతో ఏమవుతుంది? గైనకోమాస్టియా, టెస్టోస్టెరాన్ పడిపోతే if the domination of men gone, domination of women begin. So gynecomastia only with ketoconazole. Liver dysfunction, commonly we use the fluconazole to treat the Syscan under the brand, 4-can Syscan 150 milligram system. But we need to also be careful that it can lead to liver dysfunction. But any patient on fluconazole, long term we need to evaluate LFT. And azoles can lead to QT interval prolongation. So this is the fluconazole, itraconazole, clotrimazole, miconazole, voriconazole, right? And isovuconazole, Casamba. Now, terbinafine is the next one. So, all your 20 questions will come from this 200 slides. That is the fun. You see, once you do this, your 54% will become, I can guarantee, 58%. Microbiology we finish, 62. Then biochemistry, it will go to 66. At least before exam, we should be at 75%. That's sure shot to win. 15 days is everything. Yeah. And you are also actually doing scaling up. Yeah. A lot of people get pissed off in the last 15 days, but you're not like that. And yeah, how much tension, you go to reading rooms and libraries, they'll be biting nails and running here and there. If you have a clear objective what to read and how your day should pass, how to recall, what to recall, you are the winner. Knowing that only is half the journey towards winning, doctor. terbinafine. Terbinafine is an inhibitor of squalene epoxidase, which is important for once more the production of the cell wall of the fungus. So it is used for dermatophytosis like fingernail infection, onychomycosis, toenail infections, and terbinafine tablet, right? So this is a quick summary, doctor. Amphotericin B, nystatin are called polyenes. You are having azoles. Then we have terbinafine, which is allylamines. Caspofungin, they're all echinocandins. They inhibit the cell wall by inhibiting beta-1,3 glucan synthesis. Then you have flucytosine, which is DNA RNA inhibitor, which is an antimetabolite. Then greasophulvin, which is a mitotic inhibitor. And you are having the cyclopyrox, which is has multiple mechanisms. Definitely one question will ask, this belong to which class and what is the site of action? Very important table. So what is this, doctor? Terbinafine onychomycosis. Then comes echinocandins, anidulafungin, caspofungin, micafungin. So whenever aspergillosis become invasive, it will catch the blood vessel and expand and lead to necrotic lesions in multiple areas. Invasive candidiasis, very dangerous. Candida, echinocandins are used. But they can lead to release of the histamine. That's the reason there is an intense flushing of the body when you give this. That you need to be watchful. So this is anidulafungin injection. This is caspofungin injection. They are called echinocandins. This is micafungin injection. So this is the Aspergillus fumigatus, pulmonary invasive aspergillosis, where your echinocandins, echinocandins will be helpful. Okay, doc. Then greasophulvin. Greasophulvin interferes with the microtubule formation, which prevents the mitosis and prevent the fungi from multiplying. And greasophulvin can deposit in the keratin-containing tissues like nails. That's the reason tinea, ringworm, superficial dermatosis, in all this we use. But greasophulvin can cause disulfiram-like reaction. And it is a P450 inducer. That's the reason it will affect somebody taking a anticoagulant like warfarin that become over-metabolized by the induced P450 enzymes that lead to warfarin becoming ineffective. So this is how, doctor, lanosterol becoming ergosterol is inhibited by fluconazole, right? And squalene becoming lanosterol is prevented by terbinafine, and microtubule formation is interfered by greasophulvin is what we should remember. Then comes the anti-protozoal therapy. Pyrimethamine is used for toxoplasmosis. Is there any photo? Daddy. I always like the antique photos. Some of the patients' homes, we find 90-year, 100-year-old photographs also. Amazing. So, anti-protozoal. Pyrimethamine is used against toxoplasmosis. Suramin, melarsoprol is used on Trypanosoma brucei. Nifurtimox is used against the Trypanosoma cruzi. Sodium stibogluconate is used in leishmaniasis. So this is called sulfadoxin pyrimethamine, Fansidar. This is one of the very, very important antimalarial combination. And that pyrimethamine is also used for toxoplasma. How does toxoplasma present in HIV, doctor? it presents like space occupying lesion.
Okay.
So closest to differential diagnosis, CNS lymphoma, right? So you are not sure whether it is CNS lymphoma or toxoplasma. So better give 3 weeks of trial with pyrimethamine, and if that resolves, then it is toxo. If it is not, then do brain biopsy and identify CNS lymphoma and treat it, especially in HIV positive patients. Okay, right. So, doctor, let the party keep moving. Koncham ada AC on it. So, nifurtimox is used in trypanosoma cruzi. Stodium stibogluconate is used in leishmaniasis, kala azar, dum fever it is called. Huh? Then that is all. Now comes antivirals. Oseltamivir, zanamivir. What do? They inhibit the influenza's neuraminidase. That will decrease the release of the progeny viruses. And it is used for both influenza A and B. But better, it is only useful if you start within 48 hours of the sneezing. So neuraminidase, new virions are released. But once you inhibit that, new virions are not released. This is oseltamivir, fluvir, 75 milligram. We use often. BD, 5 days. Inti tablet capsules. Once I took up, I thought, how are my patients take?
What do you take?
Huh?
For what?
This is all used for viral infections.
Oh.
If you are suspecting dengue,
Yeah.
chikungunya, only option is to give fluvir.
Okay.
COVID is not affected by this, they say. Oseltamivir, fluvir.
Yeah.
Then oseltamivir, one more brand is Tamiflu, very popular when it came. Then Relenja is Janamivir. Then you have Beloxavir. What is it? There is a function called cap snatching endonuclease activity.
Yeah.
Cap snatching endonuclease activity. It is transfer of 5 cap from the cell's mRNA to the viral mRNA. That is required for the virus to perpetuate. That is prevented by Beloxavir. Especially influenza RNA polymerase ki 5 cap snatching is needed. Where cell already 5 cap ni cell mRNA nunchi viral mRNA ki it will shift.
Yeah.
That is inhibited by Beloxavir inhibits cap snatching endonuclease. These all come in an entrance. That time you should remember.
Right.
Treatment within 48 hours will help, even Beloxavir. So this is the site of action where the cap snatching endonuclease is inhibited by the Beloxavir. So this is called cap dependent endonuclease inhibitor called Beloxavir. So here you have all the activity. Neuraminidase inhibitors are oseltamivir. Then you are having a cap dependent endonuclease inhibitor.
Yeah.
Then favipiravir, ribonucleotide ఇది ఉన్నది ఆర్టీపీ అంటే ఈ లెవెల్లో favipiravir will act. Anyway, right?
Yeah.
So during the COVID, this cap snatching endonuclease inhibitors became popular. Beloxavir, right? Beloxavir. This is the typical Beloxavir tablet.
It was used to treat COVID.
Huh?
Used to treat COVID.
COVID.
Okay.
COVID లో cap snatching endonuclease ఉంటే అది multiply అవుతుంది. Inhibit అయితే
Right.
COVID will not perpetuate.
Okay.
Then remdesivir. This is very popular.
Yeah.
It is a prodrug of an ATP analog, and the active metabolite of it is a prodrug. Finally, active metabolite aitadi. It inhibits the viral RNA dependent RNA polymerase. RNA dependent RNA polymerase అని ఒక ఎంజైమ్ ఉంటుంది కోవిడ్ లో. And by inhibiting that, it will evade the proofreading. Whenever DNA is being RNA is formed, it will make mistakes. For that, you require a proofreading function done by the viral exoribonuclease. So this proofreading done by viral exoribonuclease is being prevented by the remdesivir, whose active metabolite inhibits the viral RNA dependent RNA polymerase activity. ఇది keywords గుర్తుపెట్టుకోండి. And remdesivir. So whenever the SARS-CoV-2 comes, it catches the ACE receptor. That's the reason there was a big say that its entry point is through the angiotensin converting enzyme receptor. So those who have hypertension, CHF, who are taking ACE inhibitors are more vulnerable. And that way, after endocytosis, it will come, and there is a RNA dependent RNA polymerase, and this RDRP inhibitor is your remdesivir. Favorite question. Okay, doc. Then this is the remdesivir for injection. Huh?
Yeah.
Now, acyclovir, famciclovir, valciclovir. Favorite questions of the examiner. They're all the guanosine analogs. That means they look like guanosine. They prevent the incorporation of the guanosine, and that's how they inhibit the viral DNA polymerase and terminate the chain. Right? So typically, the virus thymidine kinase will cause a monophosphorylation of these drugs. That's the reason. And after monophosphorylation, ultimately it needs to become triphosphate. Triphosphate will become by the human cell kinases will convert. But first step where it need to get monophosphorylation is done by the viral thymidine kinase. After some time, the virus will get intelligence. Amma, this bloody acyclovir, famciclovir is using my kinase and becoming monophosphorylated. So let us not monophosphorylate the acyclovir and then resistance build intelligence. Apdi no more effective. Acyclovir cannot be used. So mala cheppandi, acyclovir should get first monophosphorylated by using the viral thymidine kinase. After that, it will become biphosphorylated, triphosphorylated by the cellular kinases. Then it will compete the guanosine triphosphate integration into the DNA, and the viral replication gets stopped because the viral DNA cannot multiply. So this has no activity on CMV because cytomegalovirus by nature does not have the thymidine kinase which is necessary to monophosphorylate it initially. And it is used for herpes simplex virus induced mucocutaneous and genital lesions. Then it is used in the prophylaxis of the HSV. And it has no effect on the latent forms of the HSV and VZV. VZV means varicella zoster virus, is chicken pox. Herpes simplex virus, latent forms which are not multiplying, उसके ऊपर उनका हवा नहीं दिखा सकते. Why? Because unless it multiply, it does not require guanosine triphosphate to be incorporated.
Okay.
Guanosine triphosphate need to be incorporated into DNA. అంటే ఎప్పుడు DNA replicate అవుతుంటాయి.
Yeah.
అప్పుడు this looks like guanosine triphosphate and compete with it, no?
Yeah.
So if there is no replication, it is latent form, then acyclovir cannot be able to show its effect. Then valcyclovir is కింద ఫంక్షన్ అయిపోయిందా అడిగింది.
Yeah.
ఒకవేళ అడిగితే మనము
Yeah. We'll
shift.
Yeah. హలో రాజు కిందకి షిఫ్ట్ అయ్యవచ్చు. సరే అయిపోయాక ఫోన్ చేస్తా. I think maybe should get over soon, sir. Maybe like 15-20.
Okay. Can the online students can punch voice loud and clear? So it has no effect on latent forms. Then valacyclovir is a prodrug of the acyclovir, has a better oral availability, and that's the point. And for herpes zoster, what do we use, doctor? Famciclovir, chickenpox ki.
Yeah.
Huh? Even acyclovir and all are useful on herpes zoster, but not the latent form.
Yeah.
So what is the main side effect of these acyclovir, etc., etc.? Most important, obstructive crystalline nephropathy. It leads to formation of the stones, renal stones. It can lead to acute kidney injury if you don't hydrate the patient. And how does virus get the mutation? By mutating its thymidylate kinase, which is required for the initial monophosphorylation step of these drugs. Clear?
Yeah.
So acyclovir plus ADP become monophosphate, for which HSV thymidine kinase use. Then cellular kinases convert into triphosphate. Then typically the HSV DNA polymerase will incorporate the triphosphate instead of the actual guanosine triphosphate that inhibits the viral DNA synthesis. Clear, doctor?
Yeah.
So acyclovir and guanosine are both competitive.
Okay.
So this is the acyclovir dispersible tablet 400 mg. ఇవి 7-8 మింగాల రోజుకి చచ్చిపోతాం. 400 milligrams. This is valcyclovir 500 mg, famciclovir 500 mg, and this is obstructive crystalline nephropathy and acute kidney injury induced by it. Then comes the ganciclovir. Ganciclovir is also guanosine analog, right?
Yeah.
But cytomegalovirus, acyclovir and all are not useful. Ganciclovir is effective.
Okay.
And another important thing is what? Ganciclovir typically also is formed by mundu monophosphate by the viral kinase and triphosphate by cellular kinases. But main importance is CMV ante guanosine.
Yeah.
I mean CMV ante ganciclovir. Then valganciclovir is a prodrug of the ganciclovir, and ganciclovir can lead to myelosuppression. And just like acyclovir, the viral kinase can get a mutation and this can become ineffective. This is a ganciclovir. So there is a CMV infected cell where ganciclovir first become monophosphate by the CMVs kinase, that become triphosphate, then it will inhibit the DNA polymerase. Okay, doc? Now, there are certain drugs, Foscarnet, Cidofovir, they don't depend on the thymidine kinase for the initial monophosphate step. They become directly converted into triphosphate using the host kinases. That's the reason whenever there is any resistance to acyclovir, ganciclovir, valcyclovir, we still can use cidofovir and foscarnet. Favorite MCQ of the examiner. Valganciclovir. Now comes foscarnet. Main point. In CMV retinitis, you can use acyclovir resistant cases, you can use, but foscarnet can lead to nephrotoxicity. Nephrotoxicity and electrolyte abnormalities. I'm worried if I get allergic rhinitis, that affect your preparation. Right. Huh. So, doctor, neuraminidase inhibitors, then protease inhibitors, like that. Mechanism of action of the various antiviral, right? So, foscarnet is used intravenously for ganciclovir resistant CMV and HSV and varicella zoster, which is acyclovir resistant, is what we should remember. Then one more thing about ganciclovir is, the foscarnet is hypocalcemia, hypomagnesemia are the two important electrolyte changes. Then you have cidofovir. It preferentially inhibits the viral DNA polymerase. Cidofovir. Just before we said no, cidofovir and foscarnet. Both of them are same. Acyclovir resistant HSV we can use.
Yeah.
And important thing about cidofovir is it can lead to nephrotoxicity. That's the reason whenever you are giving cidofovir, you combine it with probenecid. Probenecid increases the tubular secretion. So probenecid and IV saline to decrease the toxicity. Ever use cidofovir? So this is the cidofovir injection, doctor. Huh? So this is how cidofovir will ultimately go and inhibit the viral DNA polymerase. Now, doctor, out of 20 questions, HIV మీద డ్రగ్స్ మీద క్వశ్చన్ లేకుంటే ఐ కెన్ కట్ మై ఇయర్. ఉత్తన షూర్ షాట్ కంపల్సరీ లాస్ట్ మూమెంట్ పెట్టుకోవాలి మీరు. రోజు నిద్ర లేవగానే వాట్ ఆర్ ద థింగ్స్ దట్ ఆర్ సో క్రూషియల్ దట్ ఐ కెన్ ఫర్గెట్?
Yeah, I started making a list.
That no?
Yeah.
You entered that phase.
Yeah.
Good. I'm glad. Huh? So now if you become lax, I will remind. If I become lax, mom will remind. We are now in a chain of custody. So, time क्या हुआ डॉक्टर साहब? ఒక మంచి కాఫీ చెప్పండి.
Yeah.
ఎంత టైం ఖతమైంది? హాఫ్ అన్ అవర్?
Yeah.
రెడీ అన్నా? ఓకే.
ఒక ఫిల్టర్ కాఫీ లేలేనండి.
ఇది ఇక్కడికి షిఫ్ట్ చేద్దాం ఈ వైర్.
యా నేను తీసుకెళ్తాను.
So 2-minute voice break. Continuing our journey, when do we use the HIV therapy? Whenever there is a low CD4 count, less than 500, 3 drugs, you should remember, 2 NRTIs, nucleoside reverse transcriptase inhibitors, and integrase inhibitor. These 2 is the most common regime to prevent the resistance. Most antiretroviral therapies are active against both HIV 1 and 2. There are 2 strains of HIV. Only exception is enfuvirtide and non-nucleoside reverse transcriptase inhibitors are not effective against the HIV-2. Exceptions. Now, what are the drugs under HIV therapy? NRTIs, what are they? Abacavir, emtricitabine, lamivudine, tenofovir, zidovudine. They're all NRTIs. What are NNRTIs? Efavirenz, nevirapine, then integrase inhibitors. Dolutegravir, elvitegravir, raltegravir, they're all what? Integrase inhibitors. Then protease inhibitors. Etazanavir, darunavir, lopinavir, ritonavir, most of the virs. Then entry, the virus need to enter into the CD4 cell, no? So that level enfuvirtide maraviroc. So total 5 classes: NRTAs, NNRTAs, integrase inhibitors, protease inhibitors, and entry inhibitors. You should remember. Now 2-3 comments about each of them. Sure, minimum 3 questions will come. A lot of people, they won't revise and get succumbed. NRTIs, abacavir, emtricitabine, lamivudine, tenofovir, zidovudine, they're all NRTIs. They competitively inhibit the nucleotide binding with the reverse transcriptase. What is reverse transcriptase? It converts RNA into DNA. Using RNA, it will convert to DNA. Normally, DNA produces RNA. DNA produces DNA. But RNA producing DNA is the specialty of this HIV. For that, they require an enzyme called reverse transcriptase. So reverse transcriptase, whenever it is getting the nucleotides to incorporate into DNA chain, that is inhibited by these drugs, which also look like nucleotides. So tenofovir is a nucleotide, you can remember. And the others are nucleosides.
Full form of NRTI.
Nucleotide reverse transcriptase inhibitors. So all these NRTIs first need to be phosphorylated, just like acyclovir and all. Then pregnancy also safe drug is zidovudine. And all these NRTIs have a problem, especially zidovudine, myelosuppression, bone marrow suppression. So when you are using this, the WBC count can fall down to 1000, 1500. Then you need to give granulocyte colony stimulating factor, GCSF, to treat. There can be nephrotoxicity because of that. Then there is a type of a mutation. Filter coffee, yeah? No filter. Thank you. No. Thank you. Doctor साहब की मेरे को on है?
Yeah.
Good amount of coffee, sir.
Yeah, twice.
So those who have HLA B5701, they have a hypersensitivity. That's the reason in them abacavir is avoided. ఇదొక స్పెషల్ పాయింట్ టు బి రిమెంబర్డ్. సో కామన్లీ నన్ను వితౌట్ కోల్డ్ కాకుండా నార్మల్ టెంపరేచర్. పురుషోత్తం లేడీ వల్ల సో lamivudine, zidovudine, nevirapine combination called diovirin, very common brand. Then abacavir lamivudine combination is used. Tenofovir emtricitabine combination is used. Atlanat, different things. Then NNRTIs, what are they? Efavirenz, nevirapine. Two things good about it. Efavirenz will give vivid dreams, suicidal. As such, you are going underneath the భూకంపం వచ్చి అందులో పడిపోతున్నట్టు అట్లాంటి vivid dreams will come with efavirenz. Similarly, nevirapine can cause Stevens-Johnson syndrome. So that's the reason. You need to remember. అంటే ఇది నార్మల్ టెంపరేచర్ ఉందా చూడండి, కూల్ కాకుండా నార్మల్ టెంపరేచర్ బాటిల్ ఉంటుంది చూడండి. నో ప్రాబ్లం. So vivid dreams are common with efavirenz. So these NNRTIs, they bind where at a site where NRTIs don't bind, because their Hawaii is not by confusing the reverse transcriptase by saying that we are also look like nucleotides. They're non-nucleotide reverse transcriptase inhibitors. Another thing, NRTI is required to be phosphorylated by some kinase for them to become active. They don't require, which is better, because otherwise if there is any dependence on any kinase, there will be a resistance. This is the efavirenz tablet. This is nevirapine, Nevimmune, very common tablet, right? Now, nevirapine can induce Stevens-Johnson syndrome, lot of times rash, etc. This is also another example of a nevirapine induced rash. Then nevirapine can cause Stevens-Johnson syndrome, toxic epidermal necrolysis, etc., etc. Then comes integravir. What are they? Integrase inhibitors. Dolutegravir, bictegravir, elvitegravir. What do? Basically, the HIV genome integrates into the host cell chromosome by binding with HIV integrase. And mana human genome loki, the viral genome will come and integrate. That is inhibited, right, by this integrase inhibitor. Mainly, you should know what is the mechanism and what are the examples of integrase inhibitor. Must. So now, doctor, this is an example of a elvitegravir tablet. Yeah, thank you. Then protease inhibitors. Etazanavir, darunavir, lopinavir, ritonavir, always. What do? Basically, the virions which are being produced to the virus require to be integrated using a HIV-1 protease. There is a pole gene inside the HIV virus which will integrate that. Integrate means it will cleave the polypeptide products of the HIV mRNA into a functional part. Assembly. Hard disk, everything you bring and assemble the laptop. And these protease inhibitors prevent the maturation by inhibiting this protease. What are the main side effects of them? Hyperglycemia, GI intolerance, they're all the ones. Similarly, if TB and HIV can coexist very often, if you are using rifampicin to treat the TB, that increases the P450 and that will increase the metabolism of these protease inhibitors, and that will lower the protease inhibitor concentration. They become ineffective. That's the reason when TB is there, instead of rifampicin, use rifabutin, which doesn't interfere with the protease inhibitors. Whenever you give protease inhibitors, the wife of the patient will come and tell you, oh, my husband become very chubby. Thank you, doctor. But actually it is not chubby. Protease inhibitors lead to peripheral lipoatrophy with central lipodeposition into the nape of the neck. Similarly, in the woman, in the breast. So that is the reason they get buffalo hump appearance. So, but overall they look like they gained weight. Because cachexia untayi kada HIV tho. Similarly, protease inhibitor lead to hyperlipidemia, insulin resistance, etc. Ritonavir among this is also a cytochrome P450 inhibitor. దాంతో ఏమైపోతుంది? If you add with other drugs, it inhibits P450 and prevent the other drug metabolism and increase their drug concentrations and drug toxicity. And overall protease inhibitors, if you combine with rifampicin will make them ineffective. Rifampicin is a P450 inducer and make them all ineffective.
They use with ritonavir.
The main problem is ritonavir can affect other drugs. Ritonavir is a P450 inhibitor. But ritonavir's metabolism is dependent on P450, which if it is induced by rifampicin can make it ineffective. That's the point. Even though it has your point is valid, but hyperlipidemia and lipodystrophy. So this is how on the nape of the neck, abdomen, fat deposits, and peripherally there will be thinning. This is called lipodystrophy, unique to protease inhibitors. Then entry inhibitors, enfuvirtide. So basically there is something called GP41 is a receptor to which the HIV virus will come. GP41 is a receptor on the CD4 helper T cell. They are the ones which are infected with HIV. And it typically will cause the entry become difficult. Similarly, Maraviroc, there is one co-receptor called CCR5 on the surface of the T cells, right? This CCR5 on the surface of T cells, which need to bind with the GP120 protein of the virus, so that the virus will make an entry. So Maraviroc goes and binds with that CCR5, which is the co-receptor. CD4 is the main receptor, then co-receptor, CCR5. If you inhibit that, the cell doesn't bind with GP120, right? So all the drugs' main intention is what? HIV is a bad company. How to avoid the bad company of our cells? So Maraviroc inhibits docking. Docking means just like aeroplane gate and this will come now. Docking. So this is how you have the GP41, GP120 on the HIV virus. Then you have the CD4 and other things. So this is the prevention of fusion and entry. Okay, doc. Then this is the enfuvirtide, which is used for injection. It's called Fujion. So summarize, doctor. CD4 inhibitors, chemokine receptor inhibitor is enfuvirtide. So virus will enter. Then it acts on reverse. It requires reverse transcription. NRTS and NRTS will prevent. Then it requires integration of the viral DNA into host genome. integrase inhibitors will inhibit. Then it undergoes transcription, translation, and then ultimately proteolytic activity, protease, will make it to organize, leading to the budding of the new virus particles. This is inhibited by protease inhibitor. Now, both in the new technology will come.
Yeah.
So this is how co-receptor CCR5 typically is inhibited by Maravirog that prevents the docking of the HIV virus. Then comes hepatitis C. So chronic hepatitis C, there are certain antivirals directed against the HCV. What is the main difference between HPV, HCV? There is a vaccine against HPV, but there is no vaccine against HCV. So we need to treat it. Lot of HCV cases we see. Renal failure patient undergoing dialysis. Dialysis machines are a very big transmitter of HCV, HIV and all. So N5-5A inhibitors, NS5A, NS5B inhibitors, NS3-4A inhibitors. Aveventi NS5A, ledipasivir, ombitasavir, velpatasavir. What is Chinnaga? Velpatasavir is a mechanism of action. NS5A. So fosbuvir, dasobuvir, NS3-4A, grajopravir, simipravir, ribavirin. Yeah. So there are various levels at which all these receptors come in the viral replication. These things will go and inhibit. Now let us take the comments. So NS5A, what is NS5A? It's a viral phosphoprotein that plays a key role in RNA replication. Right? Then Justin, which receptor? Which agent? Must more than enough. Mala the NS5A ante the 5B ante avanni kuda microbiology MD la chesukochu. All cheskuntaru. We are interventional radiologists. We treat the aneurysms in the brain. Now, so that is what we need to remember, doctor. Then comes the ribavirin. Ribavirin inhibits the synthesis of the guanine nucleotides by competitively inhibiting the inosine monophosphate dehydrogenase. Gurtuda biochemistry la ek zamane mein padhe the.
Yeah.
भारत को स्वराज आया तब विराज ने पहली बार बायोकेमिस्ट्री मई में पढ़ा. वो मई से अभी जुलाई आए तो कहाँ याद रहेंगे डॉक्टर साहब. बात गई అవునద్దు ఇప్పుడు లాస్ట్ బట్ యాక్చువల్లీ అప్పుడంతా చదివినాం కదా. నౌ ఇట్ విల్ హెల్ప్ టు నౌ డాక్టర్ ribavirin is a one which is a IMP dehydrogenase inhibitor. So ivanni kuda various drugs. Now that's all. Antivirals khatam. Are vah 117. అయిపోయా సగం డౌన్లోడ్. ఇప్పుడు టైం ఎంత అయింది? గంట. బాబా. So Doc Queen is asking, sir, in the last month shall we month ekkada unnadappa? What is the date today? July 10th. 22 days, 3 weeks is there for NEET PG, 2 weeks for FMG. Should we be doing the mock test or revising notes? Good question. See, every day one mock test lena, kahin bhi le lo, और score check करना. For NEET PG, minimum 75% score आए तो you are on the safe zone, doctor. Right? Then second thing, One day, one subject in 4 to 5 hours, you should be able to revise. Then you are ready for exam. Otherwise, no, you're not ready. You're not in the game only. Okay. So you need to know by now what is forgotten, what is important. What is important should not be forgotten. That is the simple rule to become a winner. Okay. So daily take a test, check your score, cry about, oh my God, it is still 51, 52, 53, 60%. That won't do. 75% nahi aaye to forget about getting a government seat. Right? So if you शांति के साथ रोज एक सब्जेक्ट खत्म करना, फुल स्केल ज्ञान टेस्ट देखना और टेस्ट रिजल्ट को एनालाइज करना, आई मीन मतलब रॉन्ग्स को, then you will be the winner, right? That is a secret, even if you are Amitabh Bachchan taking exam also. Correct, doctor? Is it not? A simple secret. Yeah. Now, doctor, what are the inhibitors of the cell wall synthesis? You have peptidoglycan synthesis, glycopeptides, vancomycin, bacitracin. Peptidoglycan cross-linking inhibitors are penicillin-sensitive penicillins, penicillin-resistant penicillins, anti-pseudomonal penicillins, and cephalosporins, carbapenems, monobactams. ఇవన్నీ ఏంటి? పెప్టిడోగ్లైకాన్ క్రాస్ లింకింగ్ ఇట్ విల్ ప్రివెంట్. అసలు పెప్టిడోగ్లైకాన్ సింథసిస్ ప్రివెంటెడ్ బై vancomycin, bacitracin. So this you need to have by heart. Penicillin-sensitive penicillins are ampicillin, amoxicillin. Penicillinase resistant penicillins are, the moment these penicillinases come, no? These are penicillinases. What? No, these are all penicillins. But they can be, organisms get resistance by producing penicillinase. So to overcome that, we require penicillinase resistant penicillins like neficillin, dicloxacillin, oxacillin. And piperacillin, tazobactam we use, no? Piptas, 4.5 grams.
Yes.
That is anti-pseudomonal penicillin. Then cephalosporins include first generation, second generation, third generation, fourth generation, fifth. Then carbapenems include imipenem, meropenem, atropinem, doripenem. Monobactams are estriona. Okay? So, ఇది గుర్తుపెట్టుకోవాలి మీరు. The main cell wall synthesis inhibitors. Similarly, metronidazole-like drugs will inhibit the integrity of the DNA. mRNA synthesis is inhibited by rifampicin, which will do by RNA polymerase inhibition. Gyrase, DNA gyrase is inhibited by fluoroquinolones like ciprofloxacin, levofloxacin, and quinolones like nalidixic acid, which is often used to treat the urinary tract infections. Then protein synthesis inhibitors is a quick summary. 50S, 30S inhibitors. Right? So then in that you have aminoglycosides, tetracyclines. Tetracyclines include tetracycline, doxycycline, minocycline. Aminoglycosides are gentamicin, neomycin, amikacin, tobramycin, streptomycin. Right? Then you also have glycycycline. That is also a 30S inhibitor. Example is tigecycline. Tigecycline is often used in intensive care units where the patient no response to meropenem, no response to piperacillin, tazobactam. Then tigecycline will be used. Colistin will be used in all those scenarios. So, idandi. Macrolides, what are they? 50S inhibitors. They include azithromycin, clarithromycin, erythromycin. Then what are streptogramins? Quinupristin, delphopristin. ఇవన్నీ ఏంటి? Streptogramins. Right? ఇది గుర్తుపెట్టుకోండి డాక్టర్. Then what inhibits 30S? Aminoglycosides. What inhibits 50S? Linezolid. So then comes sulfonamides and dapsone. How do they act? They inhibit the dihydroteroate synthetase. So PABA, amino benzoic acid, para amino benzoic acid plus pteridine will give rise to dihydroteroic acid, which is important for the, I think it's not here. So this sulfonide, amides and dapsone, the dapsone used in leprosy and sulfonamides, they inhibit dihydroteroate synthetase. ఒకసారి dihydroteroic acid form అయినాక it need to be undergoing reduction, and that will convert it into, dihydrofolate reductase will convert the dihydrofolate to tetrahydrofolate, and tetrahydrofolate is required for the synthesis of purines, right? That is DNA RNA, also needed for thymine in DNA, and in methionine, which is important for protein synthesis. For all that you require tetrahydrofolate, which is formed from dihydrofolate, which is, that conversion is done by dihydrofolate reductase, which is inhibited by trimethoprim and pyrimethamine. Clear, doctor? And that's the reason we combine sulfonamide with trimethoprim. We call that as Bactrim DS. That is trimethoprim sulfamethoxazole is a sulfonamide and trimethoprim. The combination is called Bactrim DS, double strength enter. For pneumocystis carinii prophylaxis, every day patient has to take this combination of trimethoprim and sulfamethoxazole. Enzymes గుర్తుపెట్టుకోండి డాక్టర్. Sulfonamide, dapsone inhibit dihydrofolate synthase, trimethoprim inhibit dihydrofolate reductase అనే పాయింట్ గుర్తుపెట్టుకోవాలి. Next, anti-TB drugs. What are they? Isoniazid prevent the mycolic acid synthesis in the TB bacillus. Ethambutol inhibits arabinogalactone synthesis. Then rifampicin, rifabutin, they are all mRNA synthesis, DNA dependent RNA polymerase inhibitors. ఇవన్నీ అడుగుతాడు MCQs. Pyrazinamide will go inside the cell. It has a mechanism inside, intracellular. That is its speciality. ఇవన్నీ బయట నుంచి అటాక్ చేస్తే మైకోబాక్టీరియం, this will go into the cell. Pyrazinamide. That is all the story, doctors. We have nailed the coffin called antibacterials, antifungals, blah, 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 blah. Then comes few concepts in the pharmacokinetics and dynamics, right? Good. Bioavailability means what? Out of the administered drug, what fraction of it could enter into the systemic circulation without any alteration, change? If you give intravenously, 100% will be bioavailability. Orally, it will be typically less than 100% because it will have an incomplete absorption. First pass metabolism. That means some of the orally drug will enter from the gut through portal circulation into liver, and in the liver it will be metabolized before releasing into systemic circulation.
Right.
That's the reason. And how do you calculate it? You will take the plot of the plasma concentration over time and you will find the area under the curve of the plasma concentration over time.
That's the bioavailability.
That is the bioavailability. Area under curve against the time. What is meant by T-half? The time at which the drug has lost half of its maximum concentration. Okay? How do you calculate the bioavailability? So you have area under curve orally, area under curve injected. So bioavailability is area under the curve orally by area under the curve injected into 100. Which curve? Concentration against the time. Then comes volume of distribution. Okay? So what is the meaning of volume of distribution? It is the total amount of the drug in the body relative to plasma concentration. Drug को दो choices है. शादीशुदा होके घर में रहना inside the blood vessel, or it become infidel and go around all tissues wherever. So how much of the drug is there in the plasma? How much of the drug is there in the outside? So the total amount of the drug in the body relative to its plasma concentration is called volume of distribution. A high volume of distribution means it went around all tissues and it has got a very low plasma concentration. Low volume of distribution means more of it remained restricted inside the blood vessel and plasma concentration is high. So whenever it is a highly plasma protein bound drug, it will remain in the blood vessel. That's the reason it will have high amount of
No,
it will have a low VD. So suppose if that protein level is affected by liver disease, liver is not producing protein, or it is lost into urine, proteinuria in kidney disease. In both the scenarios, what will happen? Amount of the protein available to bind with the drug is low, so it will be left to outside, and that will increase the volume of distribution. So very frequently asked question, क्या हुआ? Liver and kidney disease. Huh? So now, hemodialysis is useful for what kind of drugs? For hemodialysis, you can eliminate the drug if there is a drug toxicity. Drug toxicity అయిందనుకోండి, you can do hemodialysis. For which type of drugs? Those which are there in the blood, inside the vessel. That is only possible if it has got a low VD. Only the drugs with low volume of distribution, which are restricted themselves inside the blood vessel, can be hemodialyzed, is what you need to remember. So tell me, doctor, amount of the drug in the body by plasma drug concentration will give you VD, is what we need to remember. Agreed?
Yes.
So volume of distribution is given by the formula bioavailability into the dose.
Yeah.
ఎంత ప్లాస్మాలోకి వచ్చింది ఇచ్చినాక, out of the dose that you have given,
That's plasma concentration.
how much dose?
To bioavailability is amount of drug.
The bioavailability into dose will give you the total amount of the drug in the body. That by how much is there in the plasma is target concentration is equal to VD. So that way, volume of distribution, bioavailability are indirectly affecting how much dose you need to give. And it depends on volume of distribution and obviously bioavailability. Mainly volume of distribution decides how much drug you want to give in order to achieve a given therapeutic concentration. Clear? So if you take this equation, rearrange it, volume of distribution into total target concentration divided by bioavailability will give you the dose, which is called the loading dose. So for which type of drugs do you give the loading dose, doctor? Suppose for a drug, if there is a very high volume of distribution, for such drugs, the moment you give the drug, what is happening? All the drug is going outside the blood vessel into the peripheral tissues. That's the reason we need to give loading dose. Loading dose is given to the drugs which have got a high volume of distribution. Don't forget. So suppose if you want to achieve a plasma drug concentration of 50 and you have given 1000 milligram of the drug intravenously. If you have given intravenously, obviously its bioavailability is 100%. That means 100 by 100 is equal to 1. 1 into 1000. The dose divided by the plasma target concentration 50 will give you 20 liters. Right?
The volume of
Distribution. When the VD is low, that means it is staying inside the blood vessel. So what type of drugs? Highly plasma protein bound drugs are a large molecule or a charged molecule will remain inside the blood vessel and it will have low VD. Medium, if it goes into the extracellular fluid, small hydrophilic molecules, then high VD, those who are having lot of fat solubility, all tissues will have fat in the cell membrane. They will jump into the fat. Right? So if you take any human being, our body is 60% fluids, 40% solids. In that fluids, 2/3 is intracellular, 1/3 is extracellular. Out of that 1/3 extracellular, you have 80% interstitial, 20% is plasma. भैया ये याद रखना कल के नीड टू पी ची के लिए, ठीक है. Now if you look at the total body water, 60% is what? हम पानी का डिब्बा है. हम सोचते हैं कि हम प्राइम मिनिस्टर हैं, प्रेसिडेंट है. क्या है? अल्टीमेटली वी आर 60% वाटर बॉटल ओनली. 2 international leaders are meeting means 2 water cans are meeting. Understand? So now in this total body water, 14% of the body weight is interstitial, 40% of the body weight is intracellular, 6% of the body weight is the RBCs are responsible for 6% of your body weight. If you are a 100 kg man, 6 kg WBC bag, 7 kgs is permitted in the flight. Handbag. Then intravascular space is the remaining one. Now what is drug clearance? The volume of the plasma cleared out of the drug every unit time is called drug clearance. Mana plasma undi kada? Once you give the drug, the medicine is entering into plasma. So the plasma is 20% of our total body mass. Out of this, how much plasma got free of the drug for a unit time is called clearance. So clearance depends on what? It depends on the rate of elimination of the drug. More the elimination, more is the clearance. Inversely proportional to plasma drug concentration. If the plasma drug concentration is high, का मतलब clearance बहुत slow है. अगर वो low का मतलब clearance is high. So clearance is equal to rate of elimination divided by plasma concentration. And that is equivalent to elimination constant into volume of distribution. Right? So ultimately it is the volume of distribution that decides the clearance. ఇప్పుడు చెప్పండి. First is bioavailability, second is volume of distribution, third is clearance. Volume of distribution is the one which decides the loading dose. And clearance is also dependent on volume of distribution. So if you look at creatinine clearance, there is a formula called Cockcroft-Gault. 140 minus age into body weight into 0.85 by serum creatinine into 72 will give you the rate at which the kidney is clearing the creatinine. Clear, doctor? Then half-life, the time required to change the amount of the drug in the body by half. And what is steady state? It is a state of dynamic equilibrium where the drug concentration is constant. That means elimination and administration are balanced. Itna de rahe, utna ja rahe, or it is in constant rate.
This can only be achieved using IV.
Achieved
using IV, steady state.
Oral or IV doesn't matter. Once plasma concentration comes, your rate of administration or rate of elimination, if they are matching, then it will reach a steady state of plasma concentration. Question asked in exam: 4 to 5 half-lives it takes to reach the steady state. 3.3 half-lives it will take to reach 90% of steady state. చదువుతున్నారు మర్చిపోతున్నారు, చదువుతున్నారు మర్చిపోతున్నారు. మర్చిపోవడం ఏంటి? ఎలిమినేషన్. ఏ పాయింట్ విల్ కమ్ వేర్ యు ఆర్ ఇన్ స్టడీ స్టేట్. అంటే ఇంకా పెరుగుతలే స్కోరు. ఎంత ఎంత చదివినా పోతలేదు. ఎందుకు? కొత్త చదువుతుంటే మర్చిపోతున్నాం ఎక్కువ. యు ఆర్ నాట్ ఎట్ రీచ్ ఎట్ దట్ పాయింట్. 54 కదా, అది నా హోప్ యూ విల్ రీచ్ 75. ఈ 15 రోజులు కుస్తీ పడితే. క్లియర్? గుర్తుందా? సో హౌ డు యూ క్యాలిక్యులేట్ T half? 0.7 into volume of distribution by clearance will give you T half. ఈ ఫార్ములాలు అన్నీ కూడా గట్టిగా పట్టాలి డాక్టర్ సాబ్. ఇన్ ఫస్ట్ ఆర్డర్ ఎలిమినేషన్, half-life is defined as the time taken for one half of the reactant to react. That means plasma concentration should fall by one half. Clear? Then what is zero order kinetics? In the zero order kinetics, the half-life depends on both the initial concentration and the rate constant. Rate of elimination constant in the Ke, which we used for calculating clearance. Clearance is equal to Vd into Ke annanga. So Ke మీద ఇనిషియల్ కాన్సన్ట్రేషన్ మీద రెండింటి మీద డిపెండెంట్ ఇది జీరో కైనెటిక్స్ లో. అది అంటే ఒక పాయింట్ గుర్తుపెట్టుకోండి. నౌ నంబర్ ఆఫ్ హాఫ్ లైఫ్స్, వన్ హాఫ్ లైఫ్ కే బాద్ ఫస్ట్ ఆర్డర్ కైనెటిక్స్ లో, ఐఎమ్ నాట్ టాకింగ్ అబౌట్ జీరో ఆర్డర్. Zero order is fixed amount eliminated. Here fixed proportion eliminated. So one half life 50%, two half lives 25%, three half lives 12.5% remaining, four half lives 6.25. And you require how many half lives? 4 to 5 half lives to achieve 100% of steady state is what we need to remember. So loading dose is dependent on plasma concentration to volume of distribution divided by bioavailability. Maintenance dose is dependent on plasma concentration into clearance into dosage interval divided by bioavailability. Ante maintenance dose depends on clearance, loading dose depends on volume of distribution. Favorite question. Volume of distribution decides loading dose. Maintenance dose depends on clearance. Those drugs which have a very high clearance require maintenance dose. Those drugs which have got a high volume of distribution require loading dose. That's what we need to remember, doctor. Whenever there is any renal disease, liver disease, clearance will alter. Clearance will decrease, no? Because liver clearance untadi, kidney clearance untadi, drugs ki. The moment liver disease, kidney disease is there, clearance is low. If the clearance is low, maintenance dose should be low. But loading dose is not effective. Kidney disease or liver disease आने के पहले भी drug is fat soluble అనుకోండి, high VD. వచ్చినాక కూడా after you got renal and kidney disease also, the fat solubility is high. That's the reason VD remains unchanged. That's the point. Clear? Those things that affect the VD can only alter the loading dose. Now, how much time it takes to reach steady state primarily depends on T half. It requires 4 to 5 T halves before steady state concentration is achieved.
For all drugs.
All drugs. Very good. Then, whenever you take a lipophilic drug, it needs to undergo two types of reactions called phase 1, phase 2. Phase 1 is P450 dependent, and it involves reduction, oxidation, hydrolysis, where slightly polar metabolite is formed. For the drug to act, it should become a water-soluble metabolite, can only be active. Water-soluble metabolite is inactive. Lipophilic metabolite, drug is only effective. Because for the drug to act, it needs to enter into cells, no? It will only enter cells if it is lipophilic. The moment P450 acts, it causes reduction, oxidation, hydrolysis, and make it lipophilic. Hydrophilic, slightly polar, water soluble.
Then it won't enter.
That's how drug is being cleared, made inactivated by using phase 1. Then phase 2 involves methylation, glucuronidation, acetylation, sulfation, and all these reactions will lead to very polar metabolite. Right?
Yeah.
So that is phase 2. Commonly asked question, what are phase 1 reaction? What are phase 2 reactions? P450 is involved in this or that. You should answer. Clear, doctor? Now, phase 1, phase 2. Right? Phase 1, phase 2. What does it do? Geriatric patients lose their phase 1 first. Favorite question. And a P450 is affected. That's the reason certain drug toxicities are higher in geriatric patients, because they lose the phase 1 first. Okay, doc? Then what is zero order elimination? In this, the elimination is constant, irrespective of plasma concentration. Concentration high gunna, low gunna, adi like a goods train, it will be slowly removing fixed amount. So when drug toxicity is there, you want a fast elimination.
Yeah.
But irrespective of the CP, I will eliminate same way, bole to. Right? That is a problem. So plasma concentration decreases linearly with time. So what drugs are zero order elimination? Phenytoin, ethanol, and aspirin. What are the 3 drugs? You can have a P. Phenytoin, ethanol, and aspirin. It is a capacity limited elimination. Matlab kya hai? It is like our Indian banks or ticket collector in railway station. He will say. So people need to stand in queue like a zero order kinetics. Anytime traveled in train?
Yeah.
Okay. Indian train?
Yeah.
Okay, good. So this is what zero order elimination standard. Other is first order elimination. చదివితే ఎట్లా చదవాలి? ఫస్ట్ ఆర్డర్ ఎలిమినేషన్ లా చదవాలి. Clear? Now, the same amount of the drug is eliminated per unit time regardless of plasma concentration of the drug. The rate elimination, constant of rate of elimination is constant. Whereas first order elimination, the same proportion of the drug is eliminated. As the concentration drops, the elimination rate drops as well. When the concentration is high, when exam is within 15 days, you need to work like a first order. When the pressure is high, you need to play the cricket. Are we not enjoying?
Yeah.
Last 5 overs, దరిద్రం 20 ఓవర్లు ఎవరు ఆడుతాడండి? 5 ఓవర్లు గట్టిగా ఆడాలి, కొట్టి పడేయాలి 150 స్కోర్. मिगता टाइम मजा करना है. अरे जिंदगी दिया है भगवान पढ़ाई के लिए नहीं भाई, मजे में पढ़ना है. Actually speaking, you have very limited thing. You are able to see, right? Hardly it is 3 hours ఒక సబ్జెక్ట్ లేపడేయచ్చు. లాస్ట్ మూమెంట్ రివిజన్ ఇంత చదవక్కర్లే. ఇందులో నుంచి ఒక క్వశ్చన్ మిస్ అయితే అడుగుంటున్నాను. మీరు you answer a mock test, no? In that 20 pharmacology questions, if they don't come from this bloody PowerPoint, I can bet my status. Now, first order elimination, rate of first order elimination directly proportional to the drug concentration. Even if they go out of this, you know how to guess if you are good with this. Adi beauty part of the MCQ test.
Yeah.
You don't need to know everything. You need to know how to eliminate.
Yeah.
First order, most of the drugs. It is a flow-dependent elimination, whereas zero order is capacity-dependent elimination. इसके लिए enzymes fixed है. Now, what is the effect of urine pH on the drug elimination? Any ion, any drug which is in an ionized state will be trapped in the urine and lost into the urine, into the toilet. Whereas if that drug is not ionized, then it will be reabsorbed. So what we should do, whenever drug toxicity is there, to eliminate it, we need to ionize it. How do we do that? First, drugs can be weak acids, drugs can be weak bases. Weak acids, example, phenobarbital, methotrexate, aspirin, they're all weak acids. If you create a base environment, then they get ionized. A weak acid will be ionized in a alkaline environment.
Yes.
So you alkalinize the urine by giving soda bicarb injection. Then that will cause it to become ionized and lost into urine instead of getting reabsorbed. Right? If it is a weak base, example, tricyclic antidepressants, amphetamines, they're all weak bases. They are trapped in the acidic environment. So acidify the urine. That's how you will promote the excretion. So whenever any barbiturate overdose is there, sleeping pills, कोई अपने हस्बैंड के साथ झगड़ा होके स्लीपिंग पिल्स लिए तो क्या करना, सोडियम बाइकार्बोनेट देके यूरिन को अल्कलिनाइज करे तो you can ionize it and eliminate from the body. Okay. Similarly, tricyclic antidepressants, they are initially treated with soda bicarb. Why? Because tricyclic antidepressants can go and affect the sodium channels in the heart and can lead to, they can affect the cardiac activity, cardiac toxicity, right? That's the reason we give soda bicarb for tricyclic, not for elimination. I think trick. So typically, what do we do for tricyclic antidepressants? రోజు ఈ డిప్రెషన్ టాబ్లెట్స్ వేసుకోలేక ఒకటేసారి అన్ని వేసుకుంటారు వాడు. వేసుకుంటే ఏం చేయాలి? డైజిపామ్, ఆల్కలినైజ్, ఫినైటాయిన్ సీజర్స్కి. Give airway support. How cruel we are, no? He want to die. We don't not letting him to die. Then hypotension treated with crystalline infusion alkalinization. Ventricular arrhythmias by alkalinization, lidocaine, phenytoin. Prolonged QRS unte ganaka alkalinization. Bradyarrhythmias lag bote isoproterenol pacemaker. Life is miserable. ठीक है डॉक्टर? कितना टाइम हुआ?
1:45.
वाह, అయిపోయిందా పెట్రోల్?
No.
Last 30 slides.
Yeah.
I'm not losing. Otherwise, you have to read yourself.
Yeah.
Niku choice is like English movies. There's easy way and a hard way. Interrogation scene, easy way and hard way. Anything you speak can act against you in the code of law. So what is efficacy? The maximal effect a drug can produce is efficacy. We read all this.
Yeah.
Potency, efficacy.
Yeah.
During when British Raj left, Viraj read. అంటే నువ్వు ఎంత గట్టిగా అరుస్తావు చూస్తారా భయ్ అని అంటే, కిतना చిల్లాతే చిల్లావు मैं भी देखता हूं. That is what your efficacy. Potency, amount of the drug needed for giving that given effect. क्यों चिल्लाते? दूसरों को डराने के लिए. तो चिल्लाने की जरूरत नहीं है. शेर के जैसे आंखें लगाओ, चीता के जैसे, वो डर जाएगा. चिल्लाने की जरूरत नहीं है. वो क्या होता? Potency. Potency is the same effect achieved with a smaller drug concentration, high potency. Maximal amount of efficacy effect that you can produce is efficacy. Please remember that. So fundamentally, you are plotting what? Drug concentration x-axis, response on y-axis.
Yeah.
ये drug जो है ना,
More
ये more efficacious. ये तो same level of effect को बहुत थोड़ा concentration में बनाया, इसलिए potent है. Clear? Right? Then one more favorite question asked. Increasing the y-axis value will increase the Vmax. That means increase the efficacy. Increasing the x-axis value, right? If the x-axis value is more towards the left side,
more potent.
it is more potent. So left shifting of the effective concentration is high potency, less drug needed.
Is more
Huh?
efficacy.
Higher the Vmax, maximum velocity achieved is efficacy. Clear, doctor? So commonly asked question, they give a drug A, drug B. Same level of effect achieved. Hence, they are both equally efficacious. But drug A achieved at lower drug concentration, hence more potent. Here, A is more
Both potent and efficacious.
more potent and also more efficacious. Atla, different postures लगा के दिखाते. Now comes autonomic nervous system drugs. ఇంకొన్ని పార్కిన్సోనిజం డ్రగ్గులు, సైకియాట్రిక్ డ్రగ్గులు, బెంజోడైజపిన్స్, బార్బిటరేట్స్, క్యాన్సర్ డ్రగ్గులు. So that's a story, doctor. All these remaining things you will be able to complete.
Yeah, sure.
But I enjoyed.
Yeah.
150 slides we finished. ఇంకొక 30-40 ఉన్నాయి.
Yeah.
చూడండి, అవి చూసి రివైజ్ చేయండి. And sure, short to become a winner. Every day we will all meet 2-3 hours padenge, or I'll give you most concentrated content for this last 15 days. Just read that, do every day one mock test, you are the winner. Right, doc?